Hey guys, this is Dr. Matt Najad, and today I have two awesome guests, my business partner, Dr. Kyle Stanley, and the famous Dr. Ben Talay, plastic surgeon in Beverly Hills. And today we're really excited to be talking about a very hot upcoming topic. It's gained a lot of popularity over the past few years. We've been able to witness that, and it's called the lip lift surgery. And it has a lot to do with facial aesthetics and the smile. And it's actually a very cool concept that we've been part of for a long time because in dentistry, we're so focused on changing the teeth and the smile and trying to get the right proportion, a youthful smile, but we tend to look at it from only one side of the equation, which is the length of the teeth. And as a result of normal aging, grinding, chipping, wear, dental restorations, what happens is the teeth get shorter. And as we go through cosmetic rounds of treatment, we tend to make the teeth longer, oftentimes longer than they ever were, in order to kind of chase that perfect youthful smile. So there's actually a lot more involved, and I'm excited to be talking about that. And with that, I want to have Kyle Stanley kind of give the dental perspective on the smile as it relates to the lips and facial aesthetics.
Yeah, so thanks, Matt. This will be fun. With with the smile and the lips, I think the problem that we're chasing is that as dentists, we're kind of taught that we need to show a certain amount of tooth display at rest when the patient is, at rest, but also a certain amount of tooth display when they're smiling. And when we have the discrepancy there is when the problems come in. So whether we show too much or too little, we have these visual tensions that we see. And as our patients age, the smile and the tooth display at rest changes. And so that was where I really started to hone in on this problem and why I wanted to introduce this topic to dentistry.
Tell us a little bit about, going back to dental school. I remember in the clinic floor, you were taking impressions of the lips. So kind of tell me a little bit about how you discovered, I want to say discovered, how you came to realize that this should be part of our dental planning, and a little bit about the history on how this procedure as it relates to dentistry has started.
Yeah, so back in like 2008, 2009, I started reading plastic surgery journals, psychology journals. I was studying the study of beauty. And so I got really interested in this topic, and I started realizing that to have a beautiful smile and a beautiful mouth, even when you're talking, you have to show teeth. And then I started seeing that a lot of my patients in dental school actually weren't showing any teeth, but we were treatment planning young people and old people, or people that showed tooth and people that didn't show tooth, the same way. And that bothered me. So I started doing my own research, looking into how we could modify the lip. And selfishly, it was just to help us dentists. And that was where I found this plastic surgery procedure that had been around for decades, but I didn't really think anybody was doing it. And so that was when I started doing research. And so now, I introduced this topic a long time ago to the restorative dental community, just so that they know that it's possible. And so I remember talking to you about it in dental school, over a decade ago. And that was before I published the articles, or that was before I was, we were working with plastic surgeons and teaching other people. So it's been a long time in the making, but it's cool that it's finally catching on.
Yeah, and I remember you introduced the concept, you ended up writing this article on it, but we have, which we'll talk about a little bit later, but we had this difficulty finding surgeons that would do it. I remember in the first 3-4 years of our practice, you were contacting surgeons. Not a lot of them were willing to do it until you found Ben Talay. And I want to kind of have you describe that. And then I want to bring Ben on to kind of discuss his experience with the surgery, going back to when he first started doing it and talking about how it's gained in popularity and so on. So kind of tell us about the resistance we met, because you had this topic, but I saw resistance. I remember you contacting people and they were saying like, no, it's not a good procedure, etc.
Yeah, so I had a lot of resistance. I came out of dental school fired up about this, and I was lecturing and actually teaching dentists that this existed. And then they would always come up to me after the lecture and say, okay, well, who do you send your patients to? And I said, I still haven't found a plastic surgeon that
Good
will
question.
even call me back. And
Yeah.
if I do find someone, then they usually say, oh, well, that never works. They always get a scar. Oh, yeah, I did one or two in residency, or I do one every 5 years, but I don't really do those anymore. So you should probably look for something else. And I was going to what I thought were like the top plastic surgeons in LA, Orange County. None of them even called me back. The ones that did call me back, they'd say, oh yeah, we do one. We'll call you when we do one. And they
Yeah.
never did one.
Yeah.
And then when I was actually teaching, I was giving a lecture, and I had a participant, a doctor, come up to me afterwards, and she said, do you know Dr. Bentale? And I
Oh,
said,
that's so happy.
no, I don't think so. And she said, he did my lip lift.
Mhm.
And it looked amazing. Like there was no scar. And I was like, oh, wow. And she was like, I'm friends with him. I can put you in touch. And I was like, well, that'd be awesome. So Ben is like a totally different type of person. Called him, answers the first time. Hey, what's up? How's it going? And it's like, hey, I want to take you out to dinner. I want to ask you some questions. He's like, how's Thursday? I'm like, all right, sure. And Ben and I just clicked, and he got it right away. And I don't know what it was that was different. And at the time too, and Ben, you can talk about this more, but at the time you were already doing like at least 5 a week. There was
So,
something very different about you.
so when was this? Just the perspective, 2010, you're talking about it. In 2013, was that when the paper was published? I think 2013 or 15.
No, so I wrote the paper in
That's right.
2011, but it didn't get published till 2017 because I couldn't find a plastic surgeon that would work with me on showing cases.
Perfect. So
So it just sat there for years. But I think Ben and I met, I don't know, a few years ago.
years ago. Okay,
Yeah,
so
yeah.
then tell us now. So like at that point, have tell us about the lip lift at that point in time and how you've seen it kind of evolve. And I would love to hear a little bit about the different surgeries and your perspective and what's made this such a popular procedure.
Yeah, I've been doing lip lifts the past 6 years or so, 7 years probably. And I had learned them from my fellowship director, and we still use them on pretty limited cases. So it was the common understanding amongst plastic surgeons that you really only do them on older, light-skinned, thin-skinned people because there can be and often are consequences to it. So if you're going to do it, you got to do it to somebody who has very forgiving skin because it's an imperfect procedure, and that it would always be an imperfect procedure. But at that time, I moved back to LA, and I had done already in New York a bunch of kind of younger girls and had great success with them. And all of a sudden, I had all these patients who were young, beautiful girls coming into my office saying they've been looking for a long time for somebody to do it, but nobody would do it. And the more I did them, I realized, oh, it's, we're doing them incorrectly. And I did them well, even though I was doing it incorrectly at the time. I did them very well. But I started to take on the same tenets that we use during deep plane facelifting. The more I understood the deep plane facelift, which is to lift something in the face, which is a human face that's soft, pliable, and descends over time, you have to actually go release the tension that exists in the face, pull it up without any tension, and then put it back down with no tension. If you do it that way, then it's actually going to stay. If you go try to tighten things and pull things and plicate things, it's the human tissues are not made of steel. They're soft tissue. They start to pull through the stitches, they fall back down, and in their wake they leave scars and nasal widening and nasal effacement and all that. So I developed a technique that at that time I called a modified upper lip lift, which is a modification on the prior upper lip lifts based upon the subnasal or the gull wing or bull's horn upper lip lift. And the big change was that I was no longer trying to tighten things and just pull things and stitch them. I actually went into a deep plane release. So I was separating the planes within the lip in a deep layer, rolling them over each other, preserving musculature, putting it back down, and then attaching it to the densest structure around the nasal base, which is the piriform ligament, which is near the periosteum. So now it's a fixed location. Once I started doing that, I could get good results on black skin, on Asian skin, on white skin, on old ladies, young ladies, old men, young men, Filipinos, anything. And all the fears of nasal widening and scarring and effacement and changing somebody's character and architecture kind of went away. And the more I got into it, the more I started to understand the mouth dynamic, and then started to work with Kyle and you as well. And through that, then I really started to understand what perioral beauty and perioral function and perioral balance meant. And in the world of dentistry and plastic surgery, it is very, very, very poorly understood amongst all of them. Everybody has a
Yeah,
poor
both sides.
understanding of it, both sides.
Hmm.
There are very few plastic surgeons who understand uh, what occlusion has to do with phonation, with mouth closure. Uh, they understand the facial balance, maybe that part. Then there's very few dentists who understand phonation and mouth closure and facial balance. There are very few. Now that we're starting to talk about it, the dentists are like, oh, okay, I kind of get what you're talking about, because before they were just trained to make the teeth longer and longer in order to get the incisive show, because their end point was, I need to have incisive display to make somebody look good, not
Yeah.
that I need to have a good balance proportion. So even with somebody who had good occlusion and good projection and good dental height, already had good maxillary height and good tooth length, it was perfect already, but they couldn't see the teeth. They thought to themselves, okay, well, this person is already perfect, I'm just going to add on to it. And now what you just did was cause a problem, because they were already perfect. And plastic surgeons, well, they were scared to do the lip lift, and so they either do it improperly, or they try to do too much with a lip lift and don't realize that there's more teeth or projection that's needed, and they don't see kind of what's happening in the strain of the face. And so we talk about how when the face is imbalanced, you start to see strain in it, you start to see stress. And with improper occlusion, improper lip height, improper lip closure, you see the muscles around the mouth, all of them just suffering, and they're straining over years, and it ages people more rapidly.
I have a couple questions. So totally agree with all that stuff. And it's just a classic case of like, you focus on what you do, you hone in, you like really narrow your focus, and you miss the big picture a lot of the time. So I want to talk about that in a little bit. But on the lip lift surgery, so are you always doing this modified upper lip lift, or is there still indications where you do things differently?
No, so the modified upper lip lift is a deep plane lip lift. It's the most logical way to do it, because you're releasing the SMAS layer from the muscle, bringing it up, putting it back down, and the muscle contracts, preserves volume, preserves function, and you have no tension. So anything that you need for this hyperdynamic area remains intact. There is no other logical way to do it. Now, some people go and cut some skin and then just close the gap over the muscle, and the muscle, they don't realize I realize what's happening because I see it later. I go open it and the muscle was folded onto itself.
Mhm.
It didn't release, so it was folded onto itself like this, and that whole area doesn't function anymore. It becomes very stiff and fibrotic. Or some would do just muscle plication on everybody. And if you do muscle plication on a long lip, it's fine. Long lips are usually poorly functioning, they don't flex very well. The top of it's kind of poorly functioning anyways. You plicate a little bit of it, not a big deal. But if you do that on somebody with already a short lip, now you're limiting their lip mobility. So I don't like to do lip lifts the other ways. I don't like to put incisions inside the nose and try to hide them. It's the same kind of erroneous thinking that was going on with facelifting. They thought to themselves, well, you get a scar with a facelift, so I'm going to hide it. No, you're doing the facelift wrong. You shouldn't be getting a scar. Your technique is wrong. Your release and your lift is incorrect. And instead of hiding your catastrophic work that you just did on somebody with scars inside the hairline, why don't you just fix the problem in the first place? And lip lifting is the same thing. Instead of hiding the scars, put them where they're supposed to go. Keep the subunits of the face separate. Put them where they're supposed to go. And then fix the problem of the lift, which is it had too much tension, too much pull, not enough release, and not enough secure suspension. So you fix those things, which we do in a very simple 20, 30-minute surgery, and you're good. The only downside to this becomes that because you're releasing a very sensitive area with sensitive lymphatic drainage and just very reactive area, you get a longer healing time. So at the sacrifice of a 3-week to 3-month healing time, I get a much, much more predictable result on all ethnicities, on all ages, on all, so you can imagine silicone, whatever is in there, I get a much more predictable result with it.
Yeah,
Gotcha.
this was something that I never understood from a dental surgery standpoint. It never made sense to me how I would see it originally in the original articles, let's say 20, 30 years ago, plastic surgery articles. They cut away a piece of tissue and then try to suture it up. And it's like, well, no wonder you're going to get a scar. I mean, in dentistry, when we do grafting or we add volume, you have to release so that we get we get that primary closure with no tension. And so when I first started seeing Ben do it live, and we came into his practice and we're watching him, it made so much sense. And for him to say like, yeah, no one else is doing it this way, it was like, this makes so much sense. And it was super cool to see. And how you say that the healing time is longer, but you ultimately get a better result. That's totally true. And I would say for patients that are listening to this, if your plastic surgeon says, oh, you'll be back and at it, in 2 weeks and it'll totally be fine, that's not necessarily a good thing in the long term, right? In the short term, yeah, of course, you get to get back to your life, your family, your work earlier. But long term, that may mean more scarring. That may mean less mobility of the lip. I mean, Ben can talk more about that, but that's been how I've been introducing it with the dental community as well. If you want to make an omelet, you got to break some eggs, and so you have that longer healing time.
Ben, so like in the modified upper deep plane lip lift, are you cutting any muscle? Is muscle being actually shortened in the process every time, or what?
So typically, no. Typically what I do is make the incision at the base of the nose, between the nose and the lip. That way you keep your nose untouched. The whole point is you don't want to remove nose while you're doing a lip lift. It's a weird thing to do. So we make the incision there, remove the excess height of the upper lip, which some people it's laterally biased, some people it's centrally biased. It's usually laterally biased to prevent bad aging. And once I do that, I remove that tissue layer down to muscle. Then I dissect over the muscle all the way down over here to release all the SMAS and skin away from it, roll it over and put it back down.
Gotcha.
Now, if I look at somebody and I say, you know what, they already have good dental height, meaning their gums and their teeth are already good height, and their lip is too long, and even if I maximally lift it, they're still not going to have good height because their muscle is just flaccid, then I go do a muscle plication. And that means that the top 3 to 5 millimeters, something minimal, I'll take the muscle and plicate it by stitching it up to the nasal base. What that does is it's the same as cutting it away, but you're not damaging any nerves. So it just fibroses that area and shortens you a little tiny bit. I prefer not to touch the muscle. It's a dynamic muscle, just like your eyes, your mouth. It's a very sensitive muscle. Just some people, I look at it and I see it's already flaccid. They have no function. It's been splayed for so many years. It's not going to do much unless you shorten it anyways. Right. So I take the sacrifice there and do that. Otherwise, it's not a good idea to do much else to the muscle. The more you tamper with it, the more you're going to function the mobility of your mouth. And your mouth is for speech, for kissing, for appearance, for emotion, for everything. It's such a sensitive area. You don't want to impair that. You have to let it be free. And this is why I tell patients it's a, there's no nice way to say it. It's not a bad idea. It's a very stupid idea to put threads in there. People put threads in there, which has no benefit ever shown by anybody ever. It's never been shown on one single patient to have a benefit. However, almost every single person you put them in, it impairs their mobility. On some people, it adds scarring in there. So you're looking at a procedure that has no proven benefit ever, and only, or very obviously, 2 things that can go wrong with it. You are committing malpractice. That is the definition of the first violation of the Hippocratic Oath, which is you shall do no harm. You've only done harm in that case. So I think people need to respect the way the lip functions, and really, when you tamper with the face, you have to respect the natural movement of the face and how much damage you can do just by touching it.
But is it true that some people doing the procedure are routinely cutting, or are they placating all the time or cutting? Because I've heard of people.
Yeah.
I've heard of patients describe that they want to cut the muscle, shorten, et cetera, as if it's like almost their standard approach in a lot of places.
It's pretty standard to do muscle plication, which is fine. Again, if you're doing it on a flaccid muscle and it's just the upper 3, 4, 5 millimeters, it's not going to cause much harm. So that's acceptable. So people do that to try to get the tension off. I use it as an ancillary measure. So I use it as one extra thing if I just have so much muscle length. Some people use it as their primary. I don't like to use it as my primary. The people who use it as their primary, typically in facelifting, are SMAS plication specialists. So they're not deep plane. So they've seen it in the face where they go plicate some SMAS and bring it up. I don't do that because that also alters the facial musculature. It stretches it sideways. That's why you see some people have like stretched mouths after a facelift.
Right. I
Or
see that all the time with patients.
yeah, or their smile doesn't go back to normal. That's not because of just excess skin pull. It's because they went and did a SMAS plication, grabbed the zygomaticus major, minor, rhizorius, and pulled them sideways. That's one of the downsides of SMAS plication that people do not discuss very often.
Makes sense. What do you think, like when you're looking at a patient evaluating the lip form, of course, now you're looking at the dental form. I've seen, we've worked on patients together where you notice that either length needs to be shortened or lengthened, et cetera. But let's say all else ideal. What do you think is the range for the philtrum length? Like what's optimal? Is there a number or a range that you're usually factoring in your treatment planning?
Yeah, it's like a yes and a no. Both yes and no. I have guidelines. I have things that help me maximize what I can do on patients without causing mobility issues and things like that. And then I kind of look at everybody and do the best I can with them specifically. It's something I say about like fillers a lot is that our patients, none of them is a blank canvas. We can't just go pick whatever height and proportion we want. We have to look at what they have and we work within the boundaries of what their face allows us to do. Yep. So I have my guidelines. I'll tell you in general, as a general just understanding of the lip, nice lips range anywhere from 10 millimeters to about 16, 17 millimeters in height. That's like a nice length upper lip. That's a big range.
And that's philtrum.
Philtral height. Yeah, being from the base of the nose here to the top of that pink right there. So it's anywhere within that range. I don't make lips shorter than 10 millimeters. I have like 9.5 before, but I don't make them shorter because at that point, your height of your orbicularis muscle becomes so short it can't function so well. So you have to leave something. So I do leave in general 11 is my shortest, but I have gone to 10 in patients who are Russian, especially, or have from that side of the world and do have naturally shorter lips and a naturally shorter aesthetic, and always have, always will. So it's not just a trend. You have to be careful not to just go with trends. You want them to age well and still, look good in 50 years if the trend changes. And otherwise, I just look to see what most people need removed to get them the proper dental height and the proper balance.
Balance and harmony, right?
Exactly. Yeah. And I'm always taking into account, do their teeth look good as is? So every single person I look at, I say, do I like their teeth? If I don't like their teeth, I have to factor that into what I'm doing. If they're ugly teeth, I can't expose them too much. Yeah. Exactly. So I can't expose them too much. If the teeth are not long enough, I'm not going to go just take my lip lift higher because the teeth aren't long enough. No, I have to do a proper lip lift on them and then have them lengthen their teeth, or preferentially lengthen their teeth first. If they're
so this is a good point. I think that Ben brings up that was kind of what I wanted to bring to the dental community was we need to think about the lip and the teeth separately. I think in dentistry, we always thought we take wherever the lip is, we add 2 millimeters to it or 3 millimeters, and that's where the incisal edge needs to be. But like Ben said, he's not going to do a shorter lip just because the patient's teeth in the wrong position. No, they're separate pieces of the puzzle. We can move the teeth with ortho, we can move it with nether surgery, we can move it with restorative dentistry, and the same thing with the lip. If, we can compensate for this. And that's how, all three of us working on patients together has been, I think, so key in the sense that, we'll send someone over to Ben or Ben will send someone to us and, what do you think? Okay, well, I may modify this. How are you going to do this? And it's just that whole idea of keep it separate, but know what it's going to look like together.
Yeah, and specifically the issues that I see when people don't adhere to this, I'll tell you, so more common I see it from the dental side just because there are more dentists than lip lifters. Like we're we have like thousands of dentists in Beverly Hills and we have like 5 lip lifters. So what I'm seeing is they don't understand the people doing cosmetic dentistry maybe that yes, they want incisive height or showing the upper teeth, but how to get there. If somebody already has perfect teeth, they go lengthen them. And what that does is it makes them look longer. It doesn't matter if you showed the teeth and you got one benefit from that. You damage them 3 or 4 other ways. So yes, you reached your goal of showing teeth, but at what sacrifice? You also made their whole maxilla look longer now. So
it makes them look like They
they
have
look
maxillary excess,
exactly.
and
So
their
they look
facial
like they have
thirds are now off too.
exactly. So they look heavier in the front of the face now. You just did
Mhm.
that, even though you try to make them younger and sexier by showing teeth. You just made them look heavier. On top of that, what happens when the teeth are projected with veneers or they come down with veneers and you already had perfect occlusion? Now your lips are not going to close comfortably every time you are at repose. And when that happens, these muscles, the DAO and the mentalis, have to start working harder. And they do this to get the lower lip to come up and meet the upper lip. Now that person starts to look angry, frowny, and wrinkled around the lower face. And the more years that go by, the more frowny and wrinkly they get in this area. And again, you aged them. So that's the biggest problem I see, is that the dental professionals who are supposed to be worried about lip closure and phonation and lip function and mouth function completely forget about it. And they just say, okay, I'm going to make your teeth longer and big ass white horse teeth. And, you know, I made you prettier because I got one goal
Right.
achieved, even though I damaged you 5 different ways.
It,
On the lip lift side, the problem is patients come in, they look long already, and then somebody goes and does a lip lift where they already had trouble closing their mouth. Already they had trouble closing their mouth, and they go do a lip lift on top of that. Now what happens? The patient comes back to me and their face is straining. Their face, they can't even close their mouth. And they're doing this, and they have to start Botoxing this area. They just went and damaged them. Instead of telling them, listen, you have to go fix your teeth first. You have to go to a cosmetic dentist, an orthodontist, or an orthodontic surgeon and have the teeth or the maxilla or both taken back in and up. Then we can talk about shortening this height, which, if you were to shorten it, would make the whole face look better, more balanced. I just can't do it now because your teeth are in the wrong position. And that's what I see very often, too often. And I see them because they want to start Botoxing this area. Why am I getting these wrinkles? Why do I have resting bitch face, is what they call it. They keep asking me, why do people think I'm angry all the time? And I say, well, because your face is straining to close your mouth. Do you understand? And you show it to them and say, oh my God, I see. Not just that. These people with longer upper teeth, their chins start to look bad because from the side, you have a tip defining point on your chin, which is usually low and along the angle of the mandible. When the mentalis is contracting all the time, it pulls up, so the point on the chin goes higher. Now your jawline has rounded up and flattened in. So you've lost your projection. Your jawline and neck start to look worse. And this is real. This is not theory. It's not theory of maybe this can happen. I see this every single day. It is real. It's a fact. And it happens from poor mouth closure. And on top of that, they also sound a little weird and their mouths are always dry. If you notice that, they're always like, they're always like that.
it's so true, because like, you know, when I do cases, I see that people smile differently after, you know, like on a more straightforward case, I will add length that was worn away, lip is relatively ideal, and they start to smile different. It's not just the length we've added, it's the whole muscular dynamics that change. And I like to test that with the temporaries I do. I like to put them in nice temporaries and try to evaluate next week and see how the lip looks. It's amazing and it's incredible. But I've also seen the exact opposite side of that. And it's so unfortunate, but I had a patient that had come for a consult and then came back for actual treatment after she had a lip lift. And you mentioned all these things that were done, in my opinion, incorrectly or not ideal. She had shortened the upper to, it was about 7.5 millimeter philtrum length. She couldn't close. And then, do you know how impossible that is on my end? I can't make the teeth shorter without the whole occlusion. You mentioned how important the occlusion is, which is very true. I can't have the front teeth short and the back teeth long. I'd have to actually close the bite on every single tooth to make unnaturally small teeth to compensate for too much surgery. You know, like the interplay is so important. And it's just amazing that you see that aspect, because, you know, I think a lot of people, like you said, they look at one side or the other, and it's just too important to plan it together and avoid these things. Because it's like, once you have the lip lift, there's really no like reversing it, right? There's no
No, I mean,
undo.
there are in severe circumstances with skin grafts, but that's severe. Like, so you generally know there's no reversing it. And you change somebody's affect by giving them bad occlusion or bad mouth closure, lip closure. You can change their whole affect.
Yeah.
People turn into what I call, they start to have a bashful smile. And there's somebody that while they talk, they're always trying to cover their teeth. You know, it's like somebody with
We
braces.
see that often.
Yeah, and you see a kid with braces, right? And they're talking and they're smiling, but they're always like covering their teeth. So I call that a bashful smile, and it happens when the teeth are just too prominent, or they have braces. You know, it can happen either way. And they start to get what I call a downward smile. So they're smiling, but even though they're smiling, this part's still pulling them down, and they look like they have like a sad smile. And this is a real effect. You know, people always talk about theory, and maybe I'm doing this good, maybe I'm doing that bad. This is real effect that is happening, and it's a rapid domino effect that always happens every single time. So it's something that dentists have to be aware of, and plastic surgeons have to be aware of if they're going to treat the face. It's a requisite. You have to be aware of these things. Just like when you're operating the eye, you have to be aware of lag ophthalmos and poor eye closure and eyelid retraction. You know, we worry about that with the eyes, but people forget about it with the mouth.
In a lot of my lectures on cosmetic dentistry or aesthetic dentistry, I do these workshops and courses, 2-3 day hands-on things. And I try to explain that when you're looking at aesthetics, you have to look at all the different lenses. There's oral facial aesthetics, there's dentogingival aesthetics, there's facial aesthetics, and you have to make your treatment plan in a way that meets the patient's goals, but also you can't narrow yourself if you just focus on dental, gingival, or oral aesthetics without the whole face. You're missing the big point, and that's the hardest thing. When I explain that concept, I myself find myself always going back and consulting with orthodontists, with yourself, other people, like, what do you think? Because I can't treatment plan everything without collaborating. I can just identify some red flags and try to formulate a plan with the colleagues and specialists, and I think that's what's missing a lot of the time. But luckily that's been improving, especially with specialists like yourself who are so aware and so good at what you do.
And you know what's incredible is that case we did recently that we were just talking about. It's a friend of mine who I had done a lip lift on, and she had ultimately, I think, improperly done veneers. So they were very prominent, over projected, over lengthened. Yeah. And because of that, when I did her lip lift, I did a conservative one. I didn't want to go all the way. Just like with ugly teeth, I can't do it with over projected teeth because I'm going to mess up their function.
Yep.
And, you know, she wanted more, which is fine. She's a very beautiful girl. And she just, I think, either thought I had said, no, I'm not going to do more, or maybe, you know, didn't understand my reasoning and didn't want to bother me because she's such like a nice person. So her niceness made her go elsewhere and had lip lift done again. When she came back, I couldn't stop staring at her mouth. It just wasn't functioning. She already had that thing that I'm talking about where you talk and you do that a lot and couldn't close, and it was already straining here. Now it was a severe strain that was really bothering me, and I had to like Botox it right away and explain, no, listen, like this is going to age you rapidly. And she goes, I see it now. I see exactly what you're talking about. She came to you, you gave her those temps. She came and saw me right after. She's never looked prettier. First of all, she's never looked prettier than that.
Yeah.
She's balanced, and now she talks completely differently.
Yeah.
Her mouth doesn't make that sound anymore. It's completely relaxed. Her whole face is relaxed now. It doesn't strain anymore. She doesn't have an ounce of strain in her face just from you putting in the temps, reversing her to, I think, her original height probably.
And also, like, you have a trained eye, but like she shared with me that some of her followers messaged her out of the blue unsolicited and said, like, exactly, like, I noticed that your teeth were long, you probably had cosmetic dentistry, I've noticed the change and it's incredible, I could hear a lisp when you would talk. So it's not just us. This is just a follower telling. She said there was numerous, but she shared that with me. So these things, you know, are being picked up by general public, non-specialists, non-dentists, because the last thing I hate to do is like make somebody overly self-conscious about something or plan things that maybe aren't, you know, perceived, but people do perceive these things. It's such, even if they can't put their finger on it, they perceive it. That's right. The thing.
This was something that, you know, at the beginning when Ben and I were starting our collaboration years ago, I felt like he taught me a lot about plastic surgery, and I was teaching him about dentistry, right? And then it started to be like he was teaching me about dentistry even. Like, so when we would look at smiles before, when we first started talking, I was looking at, okay, this is where they smiled before, and this is where they smiled afterwards. I was looking up what was the difference in the height of the lip during the smile. And what Ben had taught, you know, both you and I, Matt, is now like look at how less strained the smile is.
The ease of the smile, yeah.
Yeah, and we never looked at that. And that's never a thing we're taught in dentistry. We're never taught to look at, are they smiling, without strain? It's always based on measuring something. And I think that was something that you've brought now to the whole oral facial club and the dental community now, is the smiling without strain. When you don't have this massive lip, especially with filler, and that's something we should go into as well, weighing it down, you smile with ease. And that's something that, like you said, Matt, her followers may notice now, because she's just smiling with ease. And our eye is so drawn to natural beauty. And what I always talk about is that it doesn't have to be natural in the sense that it's untouched by, a blade or by a dentist or something, but perceived as natural.
The target
and functions naturally.
Exactly. Yeah, natural function.
And I think the two easy things to conceptualize that people are seeing without understanding, number one is the shadowing on the face. So they see when somebody's talking and they smile big, you're getting more shadows here, more crunching, more everything, more strain across, more lines across here. So you just see more shadows kind of across the face, more dimpling and, all that. That's all, shadowing and contour issues. The other is projection. They feel something. So there's emotional projection where somebody feels angry and you feel it. And then there's projection of pleasantry and calmness within somebody, or a strain within somebody. And if they're talking with a strained affect, it will project onto you. And that's how people interact, is they get a sensation of however the other person's feeling. They understand it from the projection. They absorb it. So when people talk to somebody like her before, they feel a little tense. They might feel a little uncomfortable, or that she's uncomfortable, or there's something. Afterwards, they talk to her, everything feels softer and nicer and calmer and more pleasant. Yeah. And it's strictly from that.
And the psychology that has on them, the psychology of the smile has been studied, and it's so powerful. But basically, when you have teeth that are chipped, worn, lip that's long, when you feel like you have to strain too much, there's a million different reasons why you would be uncomfortable with your smile or not confident in it. And then no matter how hard you try, it's so hard to make that natural. It's so hard to make it look good, because you only think about all those things weighing you down. You feel uncomfortable in every environment or situation where you're forced or want to smile. So getting rid of that, it's like the most life-changing aspect of what we do. Making people generally be perceived as happier makes them actually physically happier too. There's a whole psychology of this.
Yeah, it's like happiness makes you smile and smiling makes you happy. And there's really a connection there.
Yeah, and the same goes with furrowing. So when you have furrowing in the face over here, there's a direct correlation between furrowing, anxiety, and stress, and depression even. And when people are Botoxed just for that kind of stuff, it actually slows down the cycle of depression, anxiety, and stress. Something as simple as that, because there's a psychosomatic feedback loop happening. And you're not aware of it, but it feeds back into it. Like when people grind when they sleep, it's because you have some kind of tension within you, and that's you getting it out or comforting yourself somehow. But that's part of it. And when you Botox people's jaws and you can get them to grind less, they actually are less stressful sleepers.
Yeah.
I love all this, guys. I have a couple more questions for you, Ben. Like, what was it? Oh yeah. So what part of aging, or what percentage of lip lift patients you think are the direct result of like normal aging? Because like as we age, the lip, it's normal, right, for the lip to get longer as we age, or not necessarily?
I would say it is the norm for the lip to thin, deflate, and lengthen over time for different reasons. So it is just as you would expect somebody might need a facelift or eyelid procedures or things like that. The need for the lip lift is almost as common, and that's huge. And what we see is that the SMAS and the dermis and the muscle bulk overall decrease over time, and it thins. And as that thins, the lip tends to come down a little bit, versus you have a little more volume. It projects out a touch. Very small contribution to that. Over time, the lip muscle also loses its function slowly and starts to lengthen, and you see people get floppier lips over time. And then they reach a critical point where it gets past the teeth. Once it's past the teeth, now it functions very poorly because it doesn't have a support structure behind it. So things change. So there's a lot to be said for having incisive display, other than the appearance of it, is that your lip functions better when it's in front of teeth. It functions worse when there's no teeth behind it, just like you take someone's denture out and it just flops everywhere. It doesn't have a support structure. It's a hanging muscle. It needs a backing behind it to function. So as soon as the lip lengthens past that, it goes through an exaggerated, in my opinion, and this is my belief, this is a theory, but an exaggerated aging process once it's past that, because it lengthens faster because the muscle's not holding it up anymore as much.
I also think, from what I've seen, this is just my opinion, because I've looked for this in the literature. I bet you it's there somewhere, but like I've noticed on patients and even myself, when you smile more throughout the day, the muscle has a certain tone, almost like you're exercising the muscle. So it keeps, like, someone might show nothing at rest, and if then they start smiling, all of a sudden they show 2 millimeters, because right after you smile, anybody you smile and then you relax, you show more teeth naturally for a little window, and then the more you do it. So these things all compound on each other.
100%. I see it. I see it in patients because I take so many pictures in a day, and I can get them. I say, open your mouth, and they open it, and you still see teeth. Then I say, no, close it. And I say, drop your jaw open and say, ah. And they go, ah. All of a sudden now you see no teeth.
Yep.
So you're right about that. I see it in myself also.
Yep.
Because somebody keeps telling me in a photo, stop smiling, stop smiling. I'm like, I'm not smiling. Like, stop smiling, stop smiling. I'm not smiling. It's my natural tone. No matter how much I relax it, unless I'm asleep, it's like, it's slightly up.
That's a good.
Because my natural resting tone is slightly contracted.
But then you don't sleep, so it's always.
Yeah.
Okay. What about fillers and stuff, Ben? What do you think do you think or know that fillers and things are weighing it down and accelerating this whole process? Is there a component of literally weighing things down and making this process happen faster?
Yeah, and it's multifactorial. So let's say you put a scant amount of a good product, okay, meaning not Juvederm, not Juvederm Ultra, Ultra Plus, okay? You put a good product, anything other than those, like Restylane, Refine, Define, Volura, Volbella, and you go from underneath, not from above, and you inject it into the vermilion, a responsible amount, small amount. You're not trying to make a lip out of a lip that doesn't exist. You have to just take it to the next level. You don't take it 5 levels up. Okay, you take that person's, you keep it within the limits of that person's lip. You can't deflate it and inflate it to somebody else's lip. It doesn't, shouldn't happen that way. Let's say you do that. In all likelihood, you're not going to age that person. Not much. Okay, you're just going to make it look a little volumized and fuller, or replace volume that was there before. So it's not a bad thing. The problem that we see is that people use the wrong technique or the wrong product. Juvederm Ultra, Juvederm Ultra Plus are the 2 biggest culprits of that, and they love to migrate, and they're very hydrophilic. So you inject it down here, it crawls up, or you inject from up here, it crawls up faster. And it usually migrates about 1 centimeter north of the vermilion, from what I've seen, 10 millimeters, very, very often. And the filler here will go away, but it'll just end up here. People think it got metabolized. It didn't get metabolized. It got metabolized slightly, but it just moved up north. And now it's up here. And you see that 6 months to 2 years later. And it can last 10 years. So these aren't temporary fillers. We call them temporary. Residue stays, okay, for a very long time in a very large subset of patients. So once that's happening, now you're dealing with 2 different things that are aging you. 2 or 3 actually. So one of them is that your muscle is covered now and soaked with water. And when a muscle is soaked with water, it doesn't contract very well. So now you've lost your resting tone. You get a floppier upper lip. You go through an accelerated aging process, just as if you had nothing behind it or more mass in it. It's an accelerated aging process. So they age much faster because they have no muscle function. It's heavier. So the weight is actually bringing it down, and they have nothing to contract them up. And the third thing becomes that they have an expansion effect. So you can actually have a tissue expander effect, whereas you would compare it to a tissue expander that we place for surgery. You put it under the skin, and the skin slowly starts to stretch. And the dermis and epidermal thickness can actually change while it's doing that. And the effect of that is, once the filler comes out, since the dermal and epidermal thickness changed, and you've aged during that time and stretched the skin, the second the volume comes out, now you have excess wrinkles too, because you have more surface area there than you had initially. And you've been aging, so you would have gained it anyways, and you gain more from having the filler in there. So these are certainties. They're not theories. Now, it doesn't happen to everybody.
This is like that tug of war that I talk about often, is that you have injectors, let's call them injectors, whether that's plastic surgeons or nurses or derms or whoever, and then you have dentists. So you have natural aging process, but then you add fillers into it, and now we have a lip getting longer and longer and longer. And then that same person that had their lip injected goes to the dental side and says, I need my teeth to be longer because I want to show more teeth. And the dentist makes them longer.
Yep.
And then they get more fillers and the fillers get longer. And then the teeth get longer. And finally, we have these people who their upper jaw is so long looking, even though the actual jaw is there, but the teeth, it's so long looking because the lip is so long and the teeth are so long. Yeah. And so much projection. And these are these people that you look at them and you're kind of like, I mean, we would know what it is, but you know, their family or friends just is like, I don't know what happened to him or her. I don't know what it is, but it's this tug of war, like you had said, Matt, where everyone's just doing what that one thing that they're trying to do, longer teeth, bigger life,
you know, something like that. Just insightful display.
Yeah,
and so that's where this collaboration comes in. When all of us three started working together, knowing what we have to try to figure out what we don't know, and we don't have to know everything. We just have to know, hey, we know someone who does know that side of it. You know, send them to Ben and say, hey, what do you think about this? What can we do here? And vice versa. And we've done a lot of cases like that together. But just having that global knowledge and having the conversation open. I mean, even just having a plastic surgeon, you know, like I say, on our team is something that is so essential for dentists. And I think so essential for plastic surgeons as well.
Yeah, I feel like with what you're saying, I mean, we call that the LA face. It's the classic LA face, and it's LA more than anywhere. And I think the largest simian population is actually in Los Angeles in the world. The largest amount of monkeys exists here because you just see those lips. People start to look simian. They start to obliterate the folds, heavier, more projected, and they end up with that round mouth, like the Homer Simpson.
Planet of the Apes, right?
Yeah. Yeah, and it's the Homer Simpson mouth, and you see that more and more, and it's LA. That's Los Angeles is the worst that I've seen. Unfortunately, we have the best surgeons, best dentists, but we're also a mecca for that, and have no respect for the fake anymore. And people don't understand that if something looks fake, it also is functioning poorly. It's not just that it looks fake and that's the one thing you lost. It's not functioning properly, and that's why some surgery, when it's done and you think it's natural surgery and it looks fake for some reason, it's because underneath the skin, there are things that you don't understand that are happening, and they're making the person look weird. So, you know, we have to know our own limitations and have to understand that for every intervention we do, there's a million other things happening underneath the skin that we do not understand. So when we do our intervention, we try to limit the damage we do. And that's the thing I've changed from being a cowboy and cavalier to always thinking to myself, how can I not mess them up? How can I not make something worse? How can I put it back how I found it? So if somebody else goes in there after my facelift, 10 years later, they don't need a roadmap. They don't need to go look at my operative note. They just go in and say, okay, everything's where it's supposed to be. No surprises.
Same.
That's proper surgery, proper dentistry. It's proper.
Same. Yeah. Cause I mean, like we see, like, for example, people in this area, when I teach courses, they're saying things such as like, oh, I love your beautiful, natural, real looking veneers, but patients don't want that. They want this white chiclet. They want that. I'm like, I'm in the same town as you are. I'm in the same zip code. And I see maybe one out of 10 patients will slowly guide me towards a more unnatural look, but 90% of them are very receptive to natural. So you have to be willing to put in the education and explain it to them and show it to them. But when you just say, oh, no patients want it, that's when we end up with this large population of people that look so artificial because they're not getting the right guidance and the right treatments in the first place. But I think it's so important to do it conservatively, save more of the tooth, leave options for the future, not make things compounded, become worse and worse and worse. And I'm just really, really impressed on the demand for these things and how people are educating themselves. We've been getting, I would say, like 5 or 6 times a month, someone emailing us asking, I want to schedule for lip lift surgery. And we try to tell them, like, we send them to you and say something like, you can come for a consultation here. We work interdisciplinary. We don't do the surgery. People don't realize that dentists don't do this surgery, but the word has gotten out that the lip lift and dentistry work hand in hand. So it's just in a really exciting time. And I think that we're just going to keep seeing more and more growth. Have you noticed the same? Has there been a steep rise in demand for the procedure over the past few years?
Oh, absolutely.
Right.
I'm doing, I think, well, since we've been back, like 10 a week, which, you know, for a procedure that was not very popular worldwide, that's a big thing.
I've even
And
noticed surgeons who weren't doing it when Kyle was
yeah,
going around asking people. I remember names of people that said, "No, I don't do it," and now I see it on Instagram, on
yeah,
I've
websites,
seen
etc.
it too.
So,
These
yeah,
same people that said it doesn't work now, all of a sudden they're doing it all the time.
yeah, yeah. Unfortunately, they're still using the same old techniques, which
yeah,
means they
Yes.
should also not be doing it. But
Yeah.
uh, it's got
they've
such a
seen the
big
demand.
demand. The
Yeah,
demand has increased, and for them, it's a missed business opportunity sometimes.
yeah.
And they don't want to take the time to, go learn a very easy procedure, which is, it's up to them. We all have our own
Well, that's
aesthetic
why
and
patients
goals.
have to do their research. It's tough. There's so
Yeah.
much marketing out there. That's the point of this video too. I want to be able to share this with patients when they contact us
Hmm.
so they can see all the things that go in, because it's hard to get good quality information with all the stuff that's out there. So I think I'm feeling really good about all the information that we covered and stressing the importance of planning and interdisciplinary care and focusing on natural aesthetics, not super artificial fake looks and so on. Is there anything either of you guys would like to add to this? Something we didn't cover?
No, I would just say, it's really important if you're going to be in the aesthetic world to develop good taste.
Yeah.
It's such a common, uh, it seems like common sense, but it's not very common. You just have to have good taste. Like you have to be, I don't walk around telling people I'm an artist, but you have to have the eye. You have to look at people and understand what looks pretty and delicate and nice, and realize that you might not be producing it. And if you're not, why aren't you? Why are other people getting better results than you? And you have to keep challenging yourself and learning and learning and learning.
Always.
Uh, and that you don't see it in plastics all the time. You don't see it in dentistry all the time. People just kind of go to work, they do their work, and they go home. And they
Yeah.
say, okay, my patients are happy. I'm obviously doing a good job. That's a wrong gauge. Like you need to really look past that.
Could I
This
do it
is,
better? What could be
yeah,
done
how can I do it
next
better?
time? Yeah, exactly.
Exactly. Plus, plastic surgeons stay the same until they're 80 years old because they say, well, my practice is busy. It's running. Why would I change anything?
People are
Yeah.
paying. Yep.
It's the wrong way to look at it. Why would I change a blood pressure medication when it's working fine? Well, because there's going to be better ones that are going to have less
Alternative.
side effects, that are going to, those little problems you have here and there are going to go away. So medicine has to advance, and the, cosmetic dentistry is no different. Orthodontics is no different. They have to really look at their results over and over and over again and keep asking themselves, how can I get better taste? How can I look at art on the wall and see, like, how can I paint better? How can I do everything better?
Yeah. And for me, I'm just excited that this idea has caught on. For me, like reading plastic surgery journal articles in dental school has turned into like almost a trend, in throughout the world. I mean, when Ben and I first went to Brazil to teach the Brazilians, they had never really heard about this, and now it's just exploded. So
Oh, it's
it's
huge in
cool to
Brazil.
see. Yeah, it's cool to see that this is catching on. For the patients out there, I would just say, do your research. Know that this is you're working with a team that this isn't a one-off thing. This isn't their first time doing this. They've done this multiple times, and someone that you feel comfortable with. But it's really great to have this oral facial club and a group of dentists and plastic surgeons and orthodontists that can talk and advance all of our fields together for the better of our patients, to have more aesthetic dentistry, more aesthetic plastic surgery.
I know you're my business partner and all, but you should be proud, man, because you've created awareness. You didn't invent a surgery, you didn't change the surgery, but you've changed the field by bringing awareness to this. And I'm sure if we look at the trends going on over time, it's not only for the better of the patients, but it's also going to be something that it's going to be more straightforward for dentistry. It's going to give us more natural results, less frustrated patients. Everyone's going to win from these things. And at the end of the day, if a patient doesn't want to do it, our job is to educate them and show them, not to lead them blindly down a path where you add length, add length, add length. Just as long as you at least identify and talk and open up the conversation, that's informed consent. That's important. These concepts are huge, and you should be really proud that you brought that to our field. I know Ben had already known this, but as a result of your work, I think our fields are going to collaborate so much better. And I'm just really proud of that as well. And I think it's
Thank
an
you.
exciting time for dentistry and aesthetics. going forward. I definitely want to thank both of you for all your time. This has been so informative. I know that a lot of people are going to benefit from this, and we should do it again.
Certainly.
Sounds fun. Yeah, it was great. You guys have been doing some amazing cases together, and it's just really cool to see all the results.
Bye, guys.
All right. Take care.
See you later.